We're live now. Thank you, Chair.
Thank you. My name is Councillor McTighe. I chair the Health Scrutiny panel meeting for the time being. So welcome to our final meeting of the municipal year. I'd like to welcome everybody that's here and start the meeting off by having the apologies for absence, please.
Yes, Chair, we've got apologies for absence from Councillor Brian Hubbard, Councillor Tom Morstan and Councillor Matt Story. Thank you.
Thank you. Now go on to our agenda item 2, the declarations of interest. Thank you, Councillor Rooney.
Yeah, thank you, Chair.
Has something to say?
Yes, a non-pecuniary interest in agenda item 5, the CQC report. I am currently employed by Andy MacDonald, the MP, who's had some involvement working with some residents from one of the centres that the Chief covers, just to let people know. Thank you.
Thank you, that's noted. Anyone else? No. Okay, we'll go on to agenda item number 3, the minutes of the Health Scrutiny panel held on the 21st of February last. Can we have somebody who will agree to those, that they were correct?
Agree, Chair.
Thank you very much. It's agenda item number 4, the minutes.
Sorry, Chair, I was just going to say on agenda item 4, those minutes haven't been circulated yet, so those won't be able to be agreed today. They'll have to go on to the next meeting.
Well, I know I hadn't got any because I always scream that I can't print them off, but never mind. Agenda item number 5. Now, do you still want Dominic to go? Sorry, it's only Dominic this time, isn't it? So he has to go first. It's the CQC report from the TSASC and Weir Valley NHS excuse me, Foundation Trust. And we have Brent Kilmurray. Have I pronounced it correctly? He's not here. Okay. The Director of Operations is in attendance to update us, the members, on the report. Progress made since the inspection and respond to queries from members. Over to Brent. Is Brent here? No.
Hello, Chair.
Right.
Sorry, Chair. Brent is here, but I don't know if he's having problems with his microphone because I can see him on the screen.
I can't see him. What does he look like? Ah, I'll never know now.
Okay. So
sorry, I'll stop sharing. I'll stop sharing, Chair, and then you'll be able to see Brent.
I can't see. Can Brent put his hand up in the air so I know who he is, please?
I don't even know if he can hear us at the moment because he's not reacting at all.
Oh dear. Shall we wait? Shall we move on to agenda item 6 and come back, or?
Just a second. I'll just see if I can we unmute his mic at all, Susie?
So Brent's just rang me. I'll try and give him a ring and just see if I can.
Thank you. Thank you.
I've requested for his mic to be muted.
Hello.
Oh. Hello there.
Aha.
Can you hear us okay?
I thought it might have been him because he was the only one I didn't recognise.
Hello.
Hello, can you hear us okay?
I can't hear anybody. Can you hear me?
Yes, we can hear you.
I can't hear you.
So, Caroline, what do we do in situations like this?
Has anyone got any advice?
Yeah. Caroline, yeah. Can anyone else speak for him?
I don't know. Sorry, it's Susie Blood here. I'm Democratic Services Officer and Tech Officer. I know it seems a bit silly, but could you just check that obviously your volume is to the loudest it can be on your headset? That could be a suggestion. That's one suggestion I can try.
But he can't hear us. So how can you ask him that if he can't hear us?
I wonder if I was to put my mobile phone on, I'll just test it. I don't want to create feedback, but I wonder if I try and ring Brent and kind of, he may be able to hear us, but I'll mute it so when he speaks, it doesn't come back that way.
Unless anybody knows sign language. Anybody know sign language? No? Oh, well. This is nice for my last meeting, isn't it?
Susie, I'm not able to message him because the chat's turned off. But
yeah, no problem.
I don't know whether he can look in the audio settings. So you know the 3 dots at the bottom of the screen. There's an audio setting there. I don't know whether he needs to change something in there. Maybe.
possibly.
Now we've lost him altogether.
Brent's just said, apologies for this, but Brent's just said he's going to try and log out and then log back in again.
Okay.
I wonder if it's worthwhile just beginning with the presentation.
I think so, yes. I don't think we should waste any more time on it. And then if it's successful, he can just jump in, can't he?
Yes.
Yes, okay, we'll do
I'll
that then.
share the screen then, Dominic, if that's okay. Just a second.
Dominic, are you going to talk us through it until he hopefully joins us? Thank you, thank you.
Can everyone see that?
Okay, so thank you for agreeing to have us present at the committee today. And the reason that we're here is obviously my name's Dominic Gardner. I'm Director of Operations for Teesside Cymru Valley's NHS Foundation Trust, Director of Operations for the Teesside locality. Obviously that's why I'm present today. Brent is, I don't know whether Brent can hear us or not, but Brent is the Chief Executive of the organisation. So he's present today as well, and hopefully if we can get the comms working, he'll be able to contribute to the questions and processes. So I suppose I just wanted to start by outlining why we're here today, and that's to give an update in relation to the findings from an inspection that was carried out by the Care Quality Commission in January, which was a responsive visit which took place specifically focused under the risk domain of the regulatory framework. The wards they visited were, in January they came and they visited 3 wards at Rosebery Park, 1 ward at Cross Lane Hospital, which is in Scarborough, and 1 ward at West Park Hospital, which is in Darlington. As a result of those visits, the CQC notified us about significant concerns they had about our risk management processes within those wards. I suppose just to give a sense of kind of scale, they visited 5 wards out of 65 wards that we have across the organisations, and the wards they visited were wards for adults of a working age, and also their findings incorporated our psychiatric intensive care unit as well. So as I say, this highlighted significant concerns about our risk management processes, and essentially that they were complex and difficult to follow. And what they meant by that was that they were kind of multi-layered. We had multiple forms of documentation which are outlining risk, and they had concerns about how those documents aligned during the course of a day and aligned with the electronic care record to be able to produce a consistent picture of risk in terms of the people that we were providing services for. So due to those concerns and subsequent enforcement action, the CQC has subsequently rated our acute wards for adults of working age and psychiatric intensive care units, as I've stated, that service line has been inadequate for both safe and well led. The rating is an individual service rating and doesn't affect our overall trust and CQC rating, which remains as requires improvement. So Caroline, if we could just go on to the next page. So as I say, in terms of the report, it's highlighted a number of areas that we required to take action, and a number of those areas we were already cognizant of and had a number of actions in place in relation to those. But what we also want to be really clear about is that whilst we're working to address those issues, we've also taken a significant number of immediate actions, and a huge amount of work has taken place since those January inspections, which has engaged staff, service users, and a number of stakeholders within both across the organisation and outside of the organisation. And we've absolutely not limited this work to our adult inpatient wards. We've absolutely looked at this across the whole of the organisation, not just at all of our inpatient wards and all of our community services as well. So the actions that we've taken to date include a number of rapid and quality improvement events, and as I say, involving people from different teams and disciplines, involving service users and carers, looking at how we can actually improve the risk management process and, importantly, really simplify the processes that we had in place. So one of, as I've said, the CQC key concern was about the complexity of the way in which we were assessing risk and the number of processes that were in place across the wards across the course of a day. In order to provide assurance in relation to our risk assessment and risk management processes, an audit is taking place of every inpatient record to ensure that there's an up-to-date risk assessment. So that was one of the very first actions that we took. We've also held a number of training sessions to support staff in terms of using the new process that has been drawn up as a result of the quality improvement events that people have been engaged with. So now, as I've mentioned, 100% of our inpatient wards are using that new safety summary and safety plan to assess and manage risk. In terms of the community elements, we've also done work with the community services and looked at the applicability and the rollout of that safety summary and safety plan within all of our community services, and we've created a roadmap which identifies that for all of our community patients who we'd class as either high or medium risk, they will all have a current and up-to-date safety summary and safety plan consistent with the new process by the end of April. And there are plans for the remaining individuals who would be classified probably as having a lower degree of risk to follow the same process for those individuals and ensure that everybody has a fully up-to-date safety summary and safety plan. We've also updated our supportive observation and engagement procedure, so the CQC highlighted some inconsistencies in the way in which the policy was being applied. So again, we've gone back, we've reviewed the policy, and we're rolling out training in terms of the application of that policy, and that's also a formal part of the assurance and audit process that we're undertaking. And we've also importantly reviewed and streamlined our environmental risk process. So as well as the kind of the risks that might be associated with an individual, we're also very clear that with mental health services, there are risks associated with environments. So people may or may not be aware that one of the key issues that we look at is around trying to reduce fixed ligature points that may be available within our inpatient ward environments. So we did have a programme in place which was already addressing that, particularly with regard to sanitary ware within ensuite bedrooms, and that programme's now been accelerated and is on the point of being finished in terms of phase 1. But we're continuing to kind of progress work in that area to look at other areas that may potentially present a risk in terms of environment. As I say, we've improved the training for staff around harm minimisation and risk management, and importantly, we've also introduced a practice development team for our adult inpatient wards. So each of the adult inpatient ward areas now has a practice development team within each of the locality. And that practice development team is working closely with the multidisciplinary teams, working closely with the staff nurses and the healthcare assistants in terms of training in relation to the new processes, but importantly also in terms of audit of application of those processes as well. And again, staffing has been reviewed in relation to levels of staff available within adult and patient environments, and the board has approved significant investment in terms of those additional frontline posts. Caroline, if we just move on to the next slide. So in terms of assurance and oversight, we provided assurance to the Care Quality Commission that effective systems are in place in our wards to help keep patients safe, and that further improvements are underway in terms of the improvements that I've talked to. The Trust's improvement programme is being overseen and reviewed by an external quality assurance board, so there is external scrutiny in relation to this as well, which is including representatives from NHS England and Improvement, as well as commissioners and the CQC. And to supplement our assurance and oversight, we've launched a new assurance process, which includes a whole raft of measures, including peer review from people with people who may be who are external to the organisation, reviews in terms of MDT processes, modern matron processes, and also board level processes in terms of directive visits to individual service areas. And as I say, those directive visits are very much focused on learning from incidents. So one of the issues that was highlighted in the report was around whether or not was that there was a feeling that the organisation wasn't routinely learning and systematically learning from the incidents that were occurring. So they've been changes it there in terms of, and again, I think this is something that they'd already been working in relation to, but that's been accelerated. So a new formal patient safety brief has been introduced and mechanisms for distributing that within inpatient environments and assuring ourselves that that's being done. And then we also, as I've mentioned, have a plan for a peer review in May with external stakeholders. So in terms of the ongoing improvement work, as I've mentioned, there's been significant investment released by board. So we're spending a further 3.6 million in terms of frontline staffing. So that's obviously including nurses, healthcare assistants, and other members of the multidisciplinary team. But we're also including increasing our admin cover to 7 days a week, etc., to be able to support with that. We're also making significant investment in technology. So I suppose one of the key issues in terms of the multiple processes and the layered processes that the CQC found was that actually we've got what is now, I suppose, in modern parlance, a relatively old electronic care record. There was already work in place to try and replace that with something called CETO, and that work is continuing to be accelerated. But one of the issues with the older care record is that as new requirements have developed and new documents have been developed, they've almost been bolted onto the system, so they don't flow in the most intuitive way. So one of the key first tasks that was done as a result of the quality improvement event was to make sure we consolidated all of the risk assessment and risk management area information within one area of the care record, which is the safety summary and the safety plan. And that safety summary and safety plan is now the single document that is used within our inpatient processes and our community processes to describe and understand risk and risk management processes. We've continued to, as I've mentioned, roll out the ligature reduction program, and that's moving into new areas within ward environments. And we're also investing in systems such as OxyHealth. So just to give people an understanding of what that is, that's a system whereby we have sensors in the ceiling of a bedroom, and those sensors are able to pick up respirations, heart rate, etc. And if there's any unusual movement, any unusual patterns of behaviour within the bedroom, then that would be picked up and an alert would go to a member of staff to be able to respond to that. And we've already had a scenario whereby within one of our inpatient wards, where that system has been installed, staff have been able to intervene much more quickly within a situation than they would have been able to if that system hadn't been there, and that's resulted in a positive outcome in terms of that patient's care. And I suppose as a kind of a backdrop to all of this as well, so very much focused on the actions that were taken in relation to the Care Quality Commission. The organisation has been engaged in a conversation, a dialogue with staff, with external stakeholders for a number of months now, and with our most importantly with service users and carers, about the things that we think we need to change and the things that we absolutely need to improve upon. And that has now been consolidated now into a strategic programme of change. And that is to kind of, again, so it's not we're not just responding to CQC requirements, we're also engaged in a strategic programme of change, which we recognise that we needed to undertake. So I'll stop there and take any questions. I'm not sure whether Brent can hear us. I'll just check.
Hello.
Hi, Brent. Can you hear us?
Hi, I'm joining you through a combination of video and phone, so apologies for my difficulties there, Chair.
That's fine, that's fine. It wasn't your fault. But your name's good in the book for next time.
Thank you.
Right, I have some questions. Sorry, Dominic, have you finished?
I have, yeah.
Okay.
Yes.
Brent, have you anything to add, or can we now go to questions and comments?
I'm happy to go to questions, Chair. I'm more than happy to get into anything that people want to pick up from it. Yeah.
Thank you. Well, I have some questions and comments, so I don't know whether you want to answer them or Dominic. I'll leave it entirely up to you. But I've got quite a list, and I'm sure other people will have too. The report, you know, if I had to use one word, was horrendous. And just nothing, you know, for our reputation in this area. I would like to say have any heads rolled because of this, but I don't suppose they have. Maybe I'm not in a position to say that, but that's how I feel. I feel that a lot of people have been let down by people at the top. I'd like to know why you only spoke to 2 people, 2 patients. You know, why not more? Let's face it, in that situation, I would imagine a lot of patients would be reluctant to come forward and say how they really feel for fear of repercussions. So, you know, all the more reason to speak to more than 2 people, surely. I can't understand how people were employed that couldn't follow simple instructions. You don't just pluck people off the street and say you can have the job. Presumably they have training, they have to have qualifications, etc. But this report states that they haven't followed simple instructions. Or was it simply a question of there wasn't the time to do it? I don't know, you might know. Actions in place ref issues already maintained by the Yes, you mentioned something about the actions that you have in place now were as a result of things that you noticed earlier, but they were still happening. So therefore, the actions that you put in place were the wrong actions because they were ineffective, or so you say. I saw no mention anywhere of anybody being sacked, for want of a better word. But in my opinion, somebody should have been somewhere. Somebody should carry the can. Please don't take it personally. This is just how I feel. I think in a private company, they would have been sacked long before now. I feel that it's a case of closing the stable door after the horse is bolted. You've approved additional staff, approved of them, but weren't the staff you have now approved in the first place? Are you following the same criteria for approving staff as you did before, or are you changing it? I'm sorry, it's a lot, but you know, it's very, very important, this. I would say that on the whole, I mean, I'm probably putting my head on the block here, but I would say that the whole situation is, you're not fit for purpose. They haven't done. Are you shaking your head? You're not agreeing with me?
No, I'm not agreeing with you, but you know, we'll have
Okay.
a discussion.
They haven't done what they're there to do, to protect the really vulnerable people. This report has proved that. I'd like to see regular. It was an unannounced visit, wasn't it? Well, I'd like to see that regularly. I really, really would. I think that's the only way to keep on top of this sort of thing. I mean, it even states here that leaders had failed to ensure that staff knew what they were expected to do. If the staff can't do it, and the leaders aren't expecting it, we're in a hell of a position. Excuse me. And that's all really. I don't want to appear nasty or unpleasant or ruthless or being a bully or whatever. It's my last chair of the meeting, and I just feel as if it's time. I think these things were said and brought in the open. So I don't know whom. I don't really mind who answers me. Please don't take it personally, but you know, these are our people that we're supposed to look after. It's our responsibility that they're there, and we really must ensure that what should be done is done. And clearly, this report says it hasn't been done.
Yeah, and I'm sorry for what the CQC's found. And I'm sure I speak for my colleagues when actually, you know, we're not proud to read what we've seen in the report that's come through. I'll just address. I probably won't go through your comments in order. In terms of the CQC's process, they obviously follow a set process that they adopt when they visit services. This was a triggered visit. This was a focused visit where they wanted to look at some specific things. They determined who they wanted to speak to, obviously, as they came in, and they, you know, as you pointed out, they spoke to 2 patients as they went in. I think we were, expecting that they probably want to see more, but they determined that they were able to get what they needed through talking to 2 patients. In terms of the frequency of future reviews, we know that they will be back to see us. And obviously, as a consequence of the actions that they've put in place and that we've had to respond to, we've obviously had to keep in touch with them over the subsequent weeks and months and keep them appraised of the things that we've been doing to work things through. We did have a number of things in place that had resulted from previous incidents, and I think one of the difficulties that we had was the additional complexity that had introduced to some of the processes, and that has, to some extent, affected the team's ability to follow some of those processes to the letter of the policy. So, you know, you're right to point out, well, you know, you had taken measures, but actually they haven't been necessarily working. So I think there was a challenge around some of the earlier improvements or changes that we tried to make that hadn't necessarily had the impact that was desired. And that was obviously flushed out through this process. So we've now gone back in, I think, as Dominic was probably describing to you when I couldn't hear you, to actually look at actually simplifying things, stripping things back, and connecting the people with the process so that we've got that ability for people to follow the process that we've got in place and deliver against our policies. So we've got a far greater chance of that actually working through with the system that we've got in place as things stand at the moment. We are investing significant money in additional staffing. So the board has approved that additional investment. We are in the process of going out to recruit. I think that is going to be a challenge to kind of get the recruitment, I guess, completed in terms of the supply and flow of workforce. But we are making some headway with that already. They will be, you know, good quality staff. We will follow a proper process of appointment, you know, to pick up on the point that you raised. And, you know, clearly they'll be supported, inducted, trained, and set up to succeed in the roles that we're putting them into, Chair. I think they're probably the main point. I'm not going to comment on your heads rolling point. That's not the way that we operate. I don't think, you know, that's the right approach. You know, and certainly not one that I would endorse at this stage. But I think that probably covers the majority of the points that you've raised.
Thank you. I'll throw it over now to the rest of the committee. Does anyone want to ask any questions? Alma, you were first.
Thank you. Could I ask, did this report come as a surprise, or were you aware already of some of the shortfalls that you were facing and some of the issues that were challenges?
I think there were some elements of the report that I think probably the sanctions that were adopted by the CQC we felt were a surprise. We didn't expect them to go to enforcement action as a consequence of some of the feedback that we received as part of the process. Some of the things that we had highlighted through some of the work that we've been doing on our new strategy, our big conversation, which I know that you're familiar with, had highlighted some of the issues and concerns that had obviously been subsequently identified by the CQC. But we felt that, you know, this was a fair reflection of where things stand. We have no quibbles with what the CQC have identified, and we've responded to it accordingly. We've gone back and played it, you know, absolutely with a straight bat in terms of identifying then the solutions that are required to move this forward. So, you know, from that perspective, we take the feedback as it stands.
Could I just come back, Chair, please? I think what I meant by was the report and aspects which it detailed a surprise. Were you aware in advance of what was going on, or did the CQC report show you things that weren't right, that you weren't aware of?
There were elements of the report that we weren't aware of.
Are you happy with that, Alma?
Yes, it's just more worrying, really, isn't it, in some respects?
Well,
Anybody
yes,
else have any questions? Sorry, David, do you want to come in?
Yes, thanks, Chair. I seem to remember quite some time ago we had problems with the children's services at West Lane, which we covered, and that's water under the bridge. So hopefully that's been resolved. But to have things come up like this is very distressing for us all, and the people in Middlesbrough. As you well understand, it's very distressing for you. I think we want to hear good things as well as the bad things as well. And I hear what you say, but when you address that, I mean, you say that this OxyHealth, I'm sure that's a reliable system. I don't know it personally, but you're using that just to help out rather than, you know, save money or something like that. It's a help rather than you know, something else.
Solution.
It's a solution rather than you know, something to a problem. I just worry that, are you saying that the staff can't cope, or are you saying this will help the staff to cope? Because if you've got problems there, then obviously we need to address them and need to look at that. I'm sure from your talk there, you really do know what the problems are and you are going to address them. And I hope when you come back to us later on that, you know, you can say, look, this is what we've done. We've actually done it. We've addressed them. But I'm just concerned that we had the problem with the children's services before. We've got this now. I just really feel that we've got to get on top of this and things. I'm sure you are. Thanks, Chair.
Do you want to answer that?
Yeah, I mean, that's absolutely. We want to be in a position to come back and obviously give you an update in terms of the progress that we make on this. In terms of the Oxy Health comment, Chair, it's assistive technology, so it's something that supports the staff within the setting. It's not a replacement for. It's part of the mix, if you like, of human and technological sort of responses that are now available to us that allow us to enhance safety.
Councillor Cooper, do you want to come in now?
Thank you, Chair. I'd just like to say that the NHS is supported by the general public. That was confirmed by all the people that were out clapping during the pandemic. But the support and the respect shouldn't be taken for granted, so we all have to try harder. After 14 years with the out-of-hours doctors, I know just how difficult it is getting accurate information from patients and getting patients to follow simple instructions. So I'm just wondering, is there anything councillors can do to help to improve our NHS? Thank you, Chair.
Anyone want to answer?
I mean, I don't know, Dominic, whether you want to come in on that one in terms of some of the local conversations we've been having with GPs and others.
So absolutely. So I suppose from a mental health perspective, I'm very conscious that COVID has brought enormous challenges, and we know that actually, you know, whilst there's been a national dialogue around mental health, which is really positive and is reducing stigma, we do know that we're going to expect more demand coming into the system and in all parts of the system. I think in terms of the response to that within the Teesside area, we've absolutely, through health and wellbeing boards and appearances of various scrutiny committees, we've absolutely taken a whole system response to that. And you know, we're working with colleagues in public health, we're working with colleagues in local authorities, the VCS, community sector, etc., to be able to try and make sure that actually we're able to provide services to people at the point at which they need them and in the location at which they need them. And I think what we have to remember is the vast bulk of people that we work with are all within the community. I think in terms of councillors' input, I think it's really helpful in terms of keeping the narrative around mental health alive and keeping that kind of prevalent into the forefront of conversation so that we don't lose some of the momentum we've got. But I think you're absolutely right, Councillor Cooper, in terms of we can't take the public support for granted, and we're absolutely committed to making the improvements that we absolutely need to make.
Is that okay, Councillor Cooper?
Yes, thank you, Chair. Could I just mention, I am dementia friendly, and I've been trying to persuade people to recognise the difference between dementia, people having diabetes episodes, stroke, and I think it's important that we all recognise when people are in difficulty and do our best to help. Thank you, Chair.
Yeah, thank you. Councillor Rooney, did you want to come in?
Yeah, thank you, Chair. Yeah, like the Chair, I think this is a horrendous report, and it doesn't show us in a good light at all. And for me, there are two broad areas that this covers. One is about the communication and the communication systems between those at the bottom and those at the top and all the people in the middle of that. And that seemed to fall down. So people that should have known the systems weren't working didn't know. And I'd like you to give me a little bit more reassurance on how that's being addressed. There was recommendations from a previous visit that weren't followed, and whether because that's in the report, I wonder if you can tell us a little bit more about that. And then the other broad area was around the systems and the documentation and how that was followed properly and what information was recorded. Obviously, you know, don't need to know personal information, but how did that manage to fall down so badly? And then around staffing, and I think one of the other councillors referred to this in terms of another area, are we confident that we have the right staff, the people with the correct qualifications? Because that seems to be coming out quite strongly from this report, that people really didn't know what they were supposed to be doing, which meant that they weren't filling in the right forms, or they weren't able to tell the assessors how they were operating or what they were supposed to be doing. So I'll leave it at that, because that's a number of questions. Thank you, Chair.
Thank you.
Oh,
Who would like to answer?
I wonder if Dominic could take the point about the communications, the assurance work that we're doing now.
Yeah, absolutely. So in terms of the communications, as I mentioned in the presentation, we've introduced a new assurance framework to be able to ensure that, well, to do exactly that, to provide the board with assurance that the actions that are being expected to be taken are being taken, but also conversely enables kind of frontline staff to be able to have multiple conversations with people at different levels of the organisation to be able to flag any concerns that they may have in relation to patient safety. So I suppose in terms of those assurance mechanisms, I've mentioned the practice development teams that have been put in place, and those practice development teams are working directly with the multidisciplinary teams on the wards, the nursing staff, the healthcare assistants, in terms of supporting them in terms of their learning and understanding of the new safety summary and safety plan process, and in terms of the revisions that are being made around harm minimisation policies. They're also carrying out audits of documentation. So they're auditing all safety summaries and safety plans that are in place across our adult wards, and they've done that on, at the moment, that as part of our new assurance schedule, that's going to be at least done 2 to 3 times per month in terms of providing that level of assurance. They're also observing practice, so they're observing what we call our MDT report outs, which is where the bulk of the information is discussed in relation to risk assessment and risk management. We also have our senior clinicians who are part of those MDTs. So separate to the practice development team, we've got them engaged in formally processes in terms of the MDT walkabouts, they're called, where they're going around the wards, they're checking from an environmental point of view that things are sound, they're looking at and engaging in conversation with HCAs, patients, etc., and getting feedback directly through that route. We also have a series of directors' visits, which did exist prior to the CQC visit, but are being much more focused in relation to assurance around safety. So those directors' visits they're themed across the organisation, so one month it might be adult acute wards, another month it might be learning disability community teams. But again, there's a very strong assurance theme within that as well. And I also mentioned the safety brief mechanisms that have been put in place as well. So from a communications point of view, there's an absolutely clear mechanism now in terms of the learning from serious incidents, in terms of how that's communicated from our patient safety team and receipted and noted and acted upon by all of our inpatient environments and community services where appropriate as well. We're also introducing peer review processes and in conversations with other neighbouring trusts in terms of how they support with those processes. And then obviously there'll be kind of ongoing NHSE, and CQC regulatory processes. I think in terms of the systems and documentation, as described in the presentation and as Brent mentioned, that the issue that was highlighted by the CQC was the alignment of information across a number of documents. And those documents paradoxically had been introduced because people were trying to make the wards more safe, but actually what became clear was they're just unable to maintain them to the level that was needed without introducing inconsistency because of the pace and the busyness of those environments. So from a documentation point of view, all of that's been stripped out, and going back to the electronic care record, the safety summary and the safety plan is absolutely what is driving clinical care and clinical conversations.
Is that okay for you, Councillor Rooney? Or do you want to come back in?
Yeah, thank you, Chair. Just a couple of things. The explanation you gave at the beginning about the communication systems and processes that you're putting in place, I'm hoping that you're going to come back to another one of these meetings, and I would like to see maybe a diagrammatic example of how that would operate, and maybe even a case study of somebody, you know, that could be somebody who's not real, but somebody to demonstrate how that actually operates. And I think that would be really helpful for us, particularly if you're continuing to review and to see how improvements are being made over time. I like the idea of the peer review with neighbouring trusts. I always think that's a really good idea. The alignment of the documents, it seems to me that you worked very, very quickly in a very, very short space of time, because the inspection was in January, the report was out in March, and we're now into April. So what you're talking about is very, very new. And yeah. I think that's going to need time to kind of bed in, if you like. And I'd be interested to see how that continues to operate. I think there was one more point, but I can't remember where it was now. No, I've lost it, because I'm going to the middle of my brain's run off in a different direction. So yeah, thank you for that.
Sorry, Chair.
Alma, would you like to go in now?
Yes, please. Thank you, Chair. I suppose first of all, I'm a bit surprised, or a lot surprised, that in terms of governance and reporting systems pre-inspection, that there wasn't rigorous audit systems, monitoring systems, observation processes being fed back to whoever needs to keep a very watchful eye on all of these systems. So I know you've just described, Dominic, what's going on from now on, but surely that was all going on before. And my other question at the moment is about finance and money. And you did say that there's an extra 3.6 million that's going to be invested. So I wonder where that's come from. Has it come from somewhere else as a result of the inspection? Is it money that's been reshuffled? And is it that part of the problem in the first instance was due to a lack of finance in terms of good training for staffing, sufficient staffing, adequately qualified staff? So there must be a massive financial issue around pre-inspection and post-inspection to resolve some of the problems that were highlighted in the report.
Dominic, do you want to pick up the bit about the previous arrangements? And I'll
yeah, absolutely. So in terms of previous arrangements, you're absolutely right. There were, you know, as an organisation, we measure and we audit and we do huge amounts of that type of assurance work. I think what cutting to the quick, I think what the CQC inspection highlighted was that actually in terms of our audits, what we were doing was we were auditing almost kind of in a linear fashion in terms of single documentation processes. The issue was about the alignment of a number of documents. So actually, whereas previously we would audit perhaps the risk assessment, risk management plan, we'd audit a safety brief, we'd audit the the MDT report out processes. Actually, what the CQC did was look at the flow of information across the course of a day. And I think that's a key learning point for us in terms of actually following that patient journey during the course of the day, and to take that viewpoint from audit rather than an individual document.
Is that all right, Alma? Oh, sorry, I'm sorry.
Yes, I think I understand, Dominic. I just think, obviously, as you must think, it was unfortunate in terms of the communication mechanisms, as our councillor Denise Rooney says, that they weren't more aligned, so that someone analysed the flaws within that auditing system. But anyway, that's past now, but I just wanted to know what had been in place then. Obviously, what was in place was not rigorous or not fit for purpose, but now we have. I mean, I suppose that's what we've got to look at. We've got the situation which is now much improved, hopefully. And as Councillor Rooney said, you know, when you come back to us, please, in a few months' time, we'll see the benefits of the new system and its operations.
Yeah, I think probably what might be useful to share is in terms of, obviously there's been an enormous amount of change, but most of the change has been about taking away. So taking away unnecessary layers of documentation, etc. And actually what we've seen from our staff is that they've fully embraced that. They really like the new processes because they are simpler and it does give them more time to spend with patients rather than completing documentation. So I think there's a sense of hope there. And I think the other thing that we've had positive feedback around, again, which is even more important, is that we've had feedback from service users and families whereby they've absolutely said that in terms of the new process, they really feel like they've been heard, they really feel like they've been understood, and they really feel like it maps across to their experience of their life.
Can I just say something there? When you said they feel they've really been heard, does that mean they were speaking out and nobody was listening to them?
No, I think people were listening. I think their experience of being understood is better because of the new process. So people were listening, absolutely were listening, but I think they feel that they can engage better with the new process as well. So perhaps they feel they can, I don't want to speak on behalf of service users and carers. I think we need to go back and ask them. But I'm surmising that if the new process is simpler, it's therefore easier to engage with as well.
I see. No more questions. Oh,
Sorry, I had my question on the financial aspects, Chair, if
Yeah.
you don't mind. I think Mr. Kilmurray was going to answer that. Is that
Yeah,
right?
absolutely.
you just hang fire, David. 2 minutes. Okay.
So just in terms of the councillor's point about whether this was as caused due to a lack of finances, I wouldn't say that was necessarily the case. I think what we'd say is that this has coincided with a time when our wards have become incredibly busy, particularly as a result of COVID and other pressures that we've seen. We have seen a prioritisation nationally in terms of investment in mental health. And we have been in discussion locally with commissioners about obviously some of the additional finances that will come down as a consequence of that national investment and our ability to draw on some of that. We have, as a priority, made a point of making sure that we've got enough staff on our wards, and that has in some areas led to overspends. So what we're proposing to do is to use some of those overspends to actually regularise the staff on there. So we actually plan to have higher levels of staff on there rather than having to get short-term, if you like, solutions to some of the pressures that we've seen. So they shouldn't add to the financial pressures on the overall organisation. Clearly, it is a call on some of the growth monies that come down, and is a regularising of some of the spend that we already had, which was actually done on a shorter-term basis. We're making recurrent some of the non-recurrent, if you like.
Are you happy with that, Alma?
Yes, so just in a nutshell, where did this 3.6 million come from? Did that come from some of the rejigging that you talked about just then?
That's come from looking at what our needs are and the requirements for the staffing to provide, an additional level of staff across those areas, factoring in some of the things like the practice development stuff that we've talked about, different skill mix, bringing on board peer workers and so on. And we've worked it out on the basis of all of the wards that we've got and the requirements that we've identified through that sort of planning.
So can I just ask, Chair, please, is that a lot of money, a significant amount of money in relative terms? I mean, I'm not quite sure what 3.6 million is in terms of budgets in that respect.
It's less than 1% for us, but it's still a significant sum of money for us to allow us to resource what we think is a real need.
Sorry, I didn't hear. Did you say 1%, Brent?
Less than, yeah.
Thank you. Are you finished now, Alma?
Thank you. Yes.
Okay. Councillor Cooper, you wanted to come back in?
Yes, thanks, Chair. I was just interested, you mentioned about records and things. Computers and software is a interesting profession of mine. I just wondered how you are with records. It was mentioned before you're getting a new system in. I just wonder how that's, or has it been implemented, or is it going to be implemented? Because if you have patients and things that are in multiple places, if they're in Middlesbrough, then they may have another problem there somewhere else. How are the records available across the system? Because it wasn't that long ago when it was just paper records, and you used to see a guy walking around with his trolley and things, and if they got lost, you had a problem. So I just wonder how you are with that and things, and how you are keeping up with the appropriate modern technology and software that works with other pieces of software and can be used by the staff, i.e. user-friendly. I just wonder how we are with that. Thank you.
Dominic, do you want to say something on electronic patient record, Paris, and move to CETO?
Yeah, absolutely. So in terms of our electronic patient record, it was probably, I'm dredging back in time, I think it was probably introduced around about 2008, 2009. So
Yeah.
I suppose in IT terms, it's relatively old. It has been updated and maintained obviously during that period of time. But I suppose what we have seen is that actually as practice develops, as regulatory requirements develop, there are new requirements in terms of recording that are added into the record. And I think one of the problems that we had from a CQC perspective was that actually bringing that all together, finding all of that in a single place was challenging. So in terms of the steps that we've made immediately, all of that has been absolutely consolidated into one place within the current care record, which is now called the safety summary and the safety plan. So for instance, we have to do plans for observation and engagement levels. We have to do plans for people in terms of leave. We have to obviously have an overall risk assessment and a risk management plan as well. So all of that's been brought together in one area, which makes it much more simple in terms of for the multidisciplinary teams to be able to work with that in terms of their conversations. But we're conscious that's only the first step. The real change is going to be when we introduce CETO, and CETO is a new electronic care record system which has been developed with partners from IT world, obviously, but also importantly with service user carers and our staff, and it's absolutely built on the patient journey. So when I mentioned earlier on about kind of following the patient journey, this record absolutely does that. It's very intuitive for staff to be able to use. There's also a portal that's attached to it, I understand, for service users and care, or depending on your levels of access, you can access your own record, or you could potentially give access to your record to a carer, I think, as well, but I have to double check that. So all of that was already in place, or was already being planned, but we just haven't got there quick enough in terms of the delivery of that. So that has been accepted. That again, that is to be delivered and implemented. I think, Brent, have you got the exact timescales? My understanding is
18 months.
18 months. And
Yeah.
Tees was originally going to be the first area that was going to be rolled out in, but I suppose we'd have to go back and just double check that, because a lot of staff in Tees have contributed to the design of it.
David, are you happy with that?
Yeah, I just want assurances that we're not using Windows XP and old, really outdated systems. That's I really want to be assured that we're using modern technology that is not vulnerable to attack and is fit for purpose. So you need obviously to keep up with things. I know it's expensive, but as a rolling program, that's where we need to be, and that's where we would like our health service to be. Thanks.
Chair, if I could chip in there just on that. I mean, Dominic's right that the Paris system that we operate does date back to 2008-9, but we're on about version 7.8 or something like that, and it's been through different iterations and updates and various other bits and pieces. And you know, as the councillor rightly says, you know, we do need to keep on top of these things for things like cybersecurity and various other kind of issues and problems that we may face in that sort of arena. And I can assure you that we're absolutely up to date with that and going through the right accreditations and processes for getting assurances on that.
Thank you very much.
Thank you.
Are you happy now, David?
Yes, I think so. I just don't want to be reading in the paper in 6 months' time there's been a cyber attack because we're using old software and things. But no, you've assured me that. That's fine. Thank you.
Well, as you know, we're getting cyber attacked every day, you know, right across the public sector.
I know we do. Yes, I just want to make sure that you're absolutely up to date and it's spot on. Thank you.
Okay. Well, if there's no further questions, all I can say is to Alma wants to come back in.
Yeah, I just wanted to talk for a minute, please, about staff morale. I mean, it must have been very dispiriting to have to read such a report and to have the impact in your working life from such negative comments. So I think that it must have been challenging to deal with staff morale and keep everybody afloat, as you might say, with determination to improve. So can you talk about how staff morale was in the first place, and where are we now with that? Have we successfully manoeuvred through those tricky waters?
I mean, perhaps if I kick off and Dominic can perhaps say a bit more specifically about some of the Teesside stuff. I think inevitably the morale of staff has taken a hit as a consequence of this. It's not easy for them to read this. You know, clearly we're also conscious about the impact on the confidence of service users and carers in the service. So clearly, you know, what we're trying to do is to think about how we can keep staff updated about the changes that we're making, keeping them engaged in the process, talk to them about some of the steps we're taking in terms of our journey to change, which is the new strategy and the way that we're looking to move the organisation forward, and just maintain those communication channels, keep the visibility of leaders, you know, as high as we can in these times, and keep talking about, you know, the progress that we're making and the challenges that we're trying to, you know, work through and so on. So, you know, I do think we are making some headway with that, but clearly it is a difficult time for us. I don't know, Dominic, whether you'd add anything.
Yeah, I'd probably just be reiterating what you've said. It is a challenging time. I think it's been a challenging time in Tees because of, you know, we've already mentioned West Lane, haven't we, in terms of the children's service? So there's still an impact from that in terms of morale. I think in terms of, on a brighter note, I think the response to the changes that have been made, it is a real positive. So staff see this as a change for the better. Staff sees this as a change that actually it's going to improve patient safety and therefore will improve their working lives. So I think there's that's, you know, they're on board with the change process, but absolutely nobody wants to read that about the service they provide, because all of those staff came into these jobs and these professions because they want to help people. So it's immensely challenging to read something like that.
Is that okay for you, Alma?
Yes, thank you, Chair. I'm relieved to know that people are working their way through it and on board with the changes, because ironically we're going to have staff mental health issues and well-being issues if we don't manoeuvre this absolutely carefully and properly. So I'm reassured to think that they are getting supported through this process, and thank you for what you're doing.
Okay, well, all I can say now is to Brent and Dominic, thank you very much for your input. Thank you very much. I hope we weren't too harsh with you, but, you know, it's a very, very serious issue indeed. And I'm no doubt we'll meet again.
Thank you very much.
Very welcome to stay for the rest of the meeting, but I'm sure you're needed elsewhere.
Thank you.
Thank you. Bye-bye. Bye-bye. Can we now go to, where are we? Agenda item number 6, the COVID update. Mark, I think Caroline said at the beginning you wanted to go first because you had to be away early.
The other way around, I was a little bit late to the meeting because I had a meeting with the national team about a vaccination pilot that we're looking at being part of. But
you don't need to go early?
No.
Okay.
But so, I don't know, does Craig might need to go early? So Craig maybe wants to go first.
He hasn't brought me a note, so he can't go early without bringing a note. Right, who wants to go first?
Well, Craig can go first then if he's got to be elsewhere.
Okay, so over to you then, Craig.
Brilliant, thanks, Chair. Are you okay to bring up the presentation, Caroline? Thank you. That's great. So I'm Craig Blount, Director of Commissioning Strategy and Delivery for the Tees Valley CCG, and we've met before. I was asked to give a brief update on where we are with COVID and COVID recovery, and the presentation that I'm about to talk through is in 4 parts. The first part around the vaccination programme and where we've got to with that. Second part is around the current position with remote monitoring services, a scheme that we've talked about previously. The third part is around post-COVID-19 rehab and long COVID clinics that the CCG has been working with health partners to implement. And then finally, I'll talk you quickly through where we are with elective recovery. So that's recovery of our waiting times and elective surgery at our hospital providers. Okay, so if we could move on to the next slide, Caroline. Actually, we can jump.
Sorry, can I just come in for a second there? Is anybody having difficulty hearing, or is it just me?
Am I quiet? I'll move a bit closer. Apologies for that.
That's smashing. That's better. Thank you.
No problem. Okay, so quick reminder of some of the key timescales and milestones involved in implementing the vaccination programme. So phase 1 of the programme was cohorts 1 to 9, and in November 2020, NHS England started a programme of engaging with practices to mobilise the primary care workforce to support delivering the vaccine. In December and January, that work actually went live, and a number of our practices working together through primary care networks started delivering the vaccine on the 14th of December. And we had a number of pharmacy sites that were also approved that supported with delivery. Around that time as well, we also had our local provider trusts, the foundation trusts, delivering vaccine to key staff groups and other members of the community as well. Moving into February and March time, that's when the programme really took a grip, and we had a number of additional community pharmacy sites and all of the primary care networks up and running. And you'll recall that the 2 mass vaccination centres in the Tees Valley also went live. So on the 1st of March, we had the Darlington Arena, and on the 22nd of March, the Riverside Stadium started delivering vaccines as well. Just by way of some information for you, the primary care networks and their go live dates are listed there on the slide. You can see that the Middlesbrough networks are down there. So Greater Middlesbrough and Holgate went live on the 21st of December, and Central Middlesbrough on the 11th of January, with Eston also on the 28th of December. Well, that was just for information. If we can move on, Caroline. Great, thank you. So in terms of the cohorts, cohorts 1 to 9 were our most vulnerable groups, the most vulnerable part of our population, and they started with residents in care homes for older adults and their carers, and also those aged 8 years and over, and frontline health and social care workers. And that was right back at the very beginning of the programme, with an expectation that their vaccinations would be complete, or their first vaccine offer would be complete by the 31st of January. We then worked through age cohorts, coming down in 5-year groups over a period of time, culminating in the expectation that by the 15th of April, all of those in cohorts 1 to 9 would have at least had the offer of a vaccine. And actually, the NHS as a whole was compliant with that aspiration around making that offer of the first vaccine. We can jump forward to the next slide. So we've now entered into what's been referred to as phase 2, and that's those cohorts considered less vulnerable from the pandemic, and those aged from 18 up over to 49. The program, the phase 2 program, started in March, with further arrangements being put in place with primary care networks and mass vaccination centres to look at how that element of the program would be delivered. And from April the 13th, the first age group in that cohort started to receive the offer of a vaccination. So on the 13th of April, those aged 45 to 49 started to be contacted. The expectation is that over coming weeks, as we've worked through that cohort, we'll move down in 5-year age blocks, similar to how we did with the cohorts 1 to 9. If we can move forward, Caroline. Thank you. So as we've been working through the programme, it's come to light that there are some inequalities in terms of those groups that are not coming forward and receiving the vaccination. So Dr. Janet Walker's the medical director for the CCG, and she's also our vaccination programme lead. She's been working with the primary care networks and other system leaders through the vaccination board that we have in place. And we do have public health representation on there, so Mark and colleagues do attend the board as well, to look at how we develop responses to ensure that we can make sure some of our hard-to-reach groups, those from the BAME community, homeless, asylum seekers, those with learning disabilities and other faith groups, have good access to the vaccine and actually take up the offer when it's made. So we've introduced a number of initiatives to try and increase that uptake, examples of which include on the 19th of April, we had 2 temporary vaccination clinics running from mosques, both in Stockton and in Middlesbrough, and they collectively vaccinated over 460 patients, which is a real step forward. We're also working on looking at additional temporary clinics that can be established to support particularly hard to reach communities and groups out in a community setting to further progress the vaccination rollout. The CCG has also been awarded £22,000 to support developing inequalities plans, and we've started to work up spending plans against those through the vaccination board, so input from local authority colleagues and public health to determine how we would use that resource. So as sorry?
So I'm just saying it's too small to see, but never mind.
No problem. Well, The slides hopefully will be shared afterwards, Chair. But just to give you some headlines, really, in terms of the Tees Valley, we've now been able to vaccinate over 360,000 people. So that's over 280,000 first doses and just over 80,000 second doses of the vaccine, which is great progress. You can see that there are some variations by primary care network, and the table that's on the screen, that might be a little bit too small to read at the moment, actually breaks down how many vaccinations have been delivered. How many vaccinations have been delivered across each primary care network area. And I think that's probably reflective of some of the work I've just touched on around health inequalities and the need to work with particular primary care networks and community groups to make sure that we get good coverage right across the whole of the Tees Valley population. So that work's ongoing. We do perform quite favourably with regional and national averages, and the Tees Valley as a whole is just continuing to push forward and try and make sure that we get as many vaccinations out there into people's arms as possible. If we could move forward, Caroline. So further action is ongoing to try and increase the uptake and continue the good work that's been undertaken to date. So we've got primary care networks delivering first and second doses to all those patients that were in cohorts 1 to 9. So that's anybody who's already had the first vaccine will be called, which will take place within that 12-week time frame. Recognising that we've got a lot of people out there who are keen to chase up when they'll be getting their second vaccine, and I think one of the asks that we would make of the broader health and care system, but also of our population, is to be considerate around the impact on primary care in terms of individuals phoning up their practices and inquiring when they're going to get the next vaccine. There is a commitment out there that everybody will be given their second vaccine within that 12 weeks. And what we wouldn't want to do is overburden some of our practices, our primary care networks, with unnecessary calls that just take up clinical time and prevent doctors and practice staff from continuing to deliver other frontline services. In support of the work that we've been doing, the CCG has been working with the primary care networks to provide routine updates out to all of our partners. So we have a health protection board across the south of Tees where we provide a routine update in terms of the progress that's being made, any challenges that we're experiencing, any innovations that we're taking in terms of trying to reach those hard to reach groups, etc. So that we can communicate out quite effectively to our partners and keep everybody up to speed with where the programme's at. We're continuing to work with the primary care networks, NHS England and the local medical committee to make sure that we've got good processes in place, that we're supporting the whole system and our primary care colleagues in making sure that we've got good coverage for those patients in cohorts 10 to 12, so that's those under the age of 49. We're continuing to put comms out to the public, so making sure that the right messages are out there and where possible targeting those comms at those particular hard to reach groups who haven't necessarily been as quick to come forward and take up the offer of a vaccine. And obviously there's lots of work continuing to take place around what more we could do to support health inclusion for those hard to reach groups, and making sure that the vaccine's as accessible as possible. So not requiring everybody to come into a particular centre or a particular mass vaccination site, and looking at tailoring the offer wherever possible to make it easier for people to gain access. And then obviously we get lots of requests for information and different bits and pieces that come into the CCG in terms of the number of vaccines, queries with how to access the vaccine, etc. And we're just continuing to work through some of that in the background. Sorry, Caroline. Next slide there was just a brief graphical summary to show where the vaccination delivery sites are split right across the Tees Valley. So hopefully all of our populations can access them at a convenient location. So that was pretty much it in terms of an update in terms of vaccinations. I was going to move on to the post-COVID rehab services. Oh, we've gone right through now. So we're okay to just seems to have run away with itself, the presentation there.
Sorry, great. It just, I'll bring it back up again and we'll go back from the slide we were on. I'll just be a moment.
No problem. I think it was slide 11. It's the COVID-19 remote monitoring services. I'll start talking through the slide anyway, and then we can catch up with the graphics.
No problem.
So I was just going to give a quick update there against the pulse oximetry at home and the COVID virtual ward services that we implemented during the pandemic. The pulse oximetry at home is a service that's intended to provide step-up care to individuals that are having difficulties with COVID, and hopefully prevent them needing to be admitted to hospital, so allowing people to be managed either in their own home or in a community setting. The service was established during the later part of the last year. Apologies, it's just coming up now, hopefully. There we go. Yeah, the service was established last year, and in total 1,173 individuals were referred into the service, of which 956 were accepted and managed on the service, which is great because they're individuals who otherwise might have been admitted to hospital. Of those 956, 944 have now been discharged, so the vast majority of patients have been supported in their own homes by primary care, and are now returning back to their usual lives and are continuing to operate in a normal manner. The second element of the offer that was put in place was around the COVID virtual ward, and this is in essence a step-down service, so patients who otherwise would have been in hospital being stepped down but monitored remotely by secondary care doctors and appropriate clinical staff and managed remotely. We had 559 patients through that service. What we have seen is that both the pulse oximetry at home and the COVID virtual ward, the demand for these services has dropped off significantly, which you would expect as the infection rates and admission rates into hospital have dropped away as we've progressed through this latest stage of the pandemic. So what we've looked to do is maintain that support in case we experience further peaks, but we're also looking to explore how we can make better use of the staff and the services that are available, and maybe target some of that resource at long-term conditions and those patients that have frailty or other long-term conditions that might need support and could be better managed at home rather than through hospital settings or an admission to a hospital bed. So if I could move on again, Caroline. Next bit of the presentation was basically a run through where we are with post-COVID-19 rehab and the long COVID assessment clinics. So you might have heard quite a bit about long COVID in the press. Long COVID is expected or estimated to impact 1 in 10 people who will suffer from a range of symptoms. Those symptoms can include things like fatigue, generalized pain, shortness of breath, something that's described as brain fog, anxiety and depression. They can experience a cluster of those symptoms, or they could actually experience all of them. Post-COVID-19 syndrome, which we tend to refer to as long COVID, is defined as any one of these symptoms or any combination of these symptoms that might persist for more than 12 weeks. And last year in November, NHS England issued some guidance requiring local health systems to establish assessment clinics that could pick up those individuals who were presenting with these symptoms and provide dedicated support to help manage their condition. So in the Tees Valley, we worked with local NHS partners to start to establish a local clinic and approach. And in January 2021, two support services were put in place. One, which was a consultant-led multidisciplinary team, which could be referred into via your GP. The other, which was a community single point of access led service. Again, a multidisciplinary team approach that patients could be referred into to gain necessary support for their symptoms. In both instances, GPs would undertake an initial assessment and investigations of a patient before they enter into the pathway. So obviously these services went live in January, and to date we've had 49 patients managed through the SPA Community Assessment Service and 107 that have been referred into the specialist long COVID consultant-led clinic with the hospital. Following assessment, patients are referred to existing services, so things like therapies and rehab services, but there is that MDT assessment of their needs and a care plan developed around how best to support the individuals. In terms of the scope of work that we've got in place now, the pathways have been implemented in line with national guidance. We've been working on making sure that those pathways are integrated as far as possible so that there is no duplication or overlap and that patients aren't having to repeat their story on numerous occasions like we've heard in the past. We're trying to understand what patient needs are, and the service is continuing to evolve as we go along, because a lot of this is new. It's not only new to us, it's new to everybody in the country as we come out of this current phase of the pandemic. We've been working to understand what the workforce needs and service gaps might be. So where there is, or if there is a commission gap, then we will look to put that right. Where we perhaps haven't got the workforce that we might want moving forward, then we can start to work with our providers and education establishments to look at how do we plug those gaps, both in the short term but longer term as we move forward. And I think that, you know, one of the key things is that we're looking to ensure that we facilitate or promote positive patient experience and support, wherever possible, self-management. So there is a clear understanding of what patients should expect if they are diagnosed with the long COVID condition, and the support that's available for them, but also what they can do to help improve their position themselves. Okay, if we could move on, Caroline, that'd be great. Right. Just in terms of the next slide, there is quite a bit of literature available across the Tees Valley now to help individuals who've been diagnosed with long COVID, or those who've had COVID, to understand what might happen next. So we've got the Your COVID Recovery National website, which is available to anybody up and down the country. We've got the Getting Back to Work guide, which is being produced by a range of occupational health therapists and the TUC for both workers and employers. At a very local level, the CCG's produced a YouTube video, which was produced by our respiratory lead, Claire Adams, which provides some really useful help and advice on recovery from COVID and what to expect. And I think there is a link that I can share afterwards. And on the CCG's website, we've got a dedicated page full of resources that can help individuals with information guides covering things like shortness of breath, how to get appropriate exercise, psychological support that is available, and just general recovery advice as well. But there's a whole suite of websites and links that I can share after the meeting. Okay, so our final couple of slides now on COVID elective recovery. So this is basically a bit of an update in terms of where we are with our waiting times position and the elective programme, predominantly at South Tees Trust, recognising that this is the Middlesbrough Scrutiny Committee. So if you could move on there, Caroline, for me. Doesn't want to play a ball today, does it? There we go. Okay, so again, a bit of background. Nationally, COVID's had a massive impact on the elective programmes right across the country. So waiting times have increased at a national level, and the number of patients that receive planned operations over the last year reduced significantly over historic trends. That said, South Tees Hospital Trust did support 4,000 COVID patients over the last year. So that's 4,000 patients admitted through the hospital with COVID, and around 2/3 of those were admitted during the winter period. So you would expect that to have a significant impact on the planned work that they could undertake. However, what's really positive to report is that during the pandemic, South Tees were able to continue to provide routine operations. So 23,000 operations took place, of which 14,500 were planned surgeries. So that's people on an elective waiting list who were still able to go in and have things like their hip and knee replacements that they might have been waiting for. Moving forward, there's some clear national expectations around recovery of elective programmes. So by the end of April this year, so April 2021, there's an expectation that elective activity will be back to 70% of pre-pandemic levels. So that means 70% of the operations that would have took place in April 2019 should take place in April 2021. That is expected to rise to 85% of pre-pandemic levels by July. So you can see there's quite a steep recovery trajectory expected. Currently working with all of the providers across the Tees Valley patch to make sure that we're able to deliver that, and wherever possible push on and exceed those levels, pushing towards 100% where we can. In terms of the absolute latest position, South Tees hospitals are still managing COVID patients. So as of yesterday, there was 21 COVID patients in the hospital occupying hospital beds, 5 of which were in critical care. And that would be displacing patients who otherwise would have been coming in for planned operations. The trust is, however, providing a full elective programme. So if you are on a waiting list waiting for an operation, then there is an expectation that the programme is running and you will be called. It just might take a little bit longer than we'd originally anticipated. So some specific action that's been taken to address that. We're working as a collective NHS system to look at how we can further develop our operational plans for 21-22 this financial year, and that work is ongoing. Some of the key aspects of that work are around addressing the health inequalities that we've got across our system, but also understanding some of the pressures on our workforce now. We've got people who've been working flat out for over 12 months as they've responded to the pandemic, and now we're asking those individuals to support with recovery as well. So it's a big ask, and we need to make sure that the workforce is supported. In terms of actually reducing the backlogs that we've got, there's a number of actions that are being taken to help support anybody whose non-urgent care has been disrupted by the pandemic. So that would include things like we're looking at wait list initiatives and making sure that those patients that are still waiting are ready, fit, willing and able to undergo their procedure. That we're maximising the use of the independent sector. So we're quite fortunate on Teesside that we've got a number of independent sector providers on our doorstep, undertaking a whole range of procedures, including ophthalmology, orthopaedics and general surgery. So we're looking to use those where we can. Waiting list validation and clinical prioritisation of patients, so making sure that those patients with the greatest clinical need are treated first. And then wherever possible, offering patients alternative choice of providers. So if we know that there are other providers that could perhaps provide you with your treatment sooner, then giving patients that option to choose to experience their treatment somewhere else. So that might be an example of if North Tees Hospital's got a slightly shorter waiting time for a particular procedure, we could offer patients the opportunity to move across to that provider or to continue to wait at James Cook and receive their treatment there, and vice versa. Across different specialties and different types of procedure, the waiting times vary from provider to provider. But the key thing for us at the moment is making sure that our patients are offered the earliest possible date for their treatment within an NHS facility. And that is it. So I've whistled through those slides with some support there from Caroline, but more than happy to take any questions, Chair, which I'll try to respond to.
Well, before I open it up, excuse me, to the panel, I don't have any questions, but I do have a comment to say that what I'm sure what we hear from you with regard to the effort that all these people who are involved in handling this terrible situation that we have, what we hear is only the tip of the iceberg, I'm sure. And when I hear people say, "Oh, it's only this, it's only that," and you read a lot of things on social media, you hear the right answers. You go on the ward and you see for yourself. I think they have done a tremendous effort in dealing with us and helping with us. And if it was possible, I would double the salaries, but obviously we can't. And all praise to everybody from the top to the very, very bottom. You've done us proud. You really have. Any questions? Who is it, David? Can you, David?
Yes, thanks, Chair. Yes, no, we can see that I've reported that things are very low now, which is good. We're back to where we were perhaps September time, something like that. Now we're unlocking. It still bothers me that people are walking around without masks. I was in the town centre last week and people in shops. Some were following the rules perfectly, others were not following the rules, and including people serving in the shops. So it still concerns me that something could take it up. The other thing as well, the CEO of Pfizer stated that anybody that had their injection will need a boost for not only the new variants, but later on in the year. I've only seen it mentioned for people on 70 plus. I presume there's going to be plans for everybody to take it, but that's going to be a heck of a big undertaking. Do you see that affecting things in the future? Is that going to affect your clinical operations and things like that? Because if we're going to all have to go through this again, how do you see that as affecting things? Thanks, Chair.
Thanks, Councillor. I think we've got to be realistic, and there's a high likelihood that we will need a booster vaccination program. We already have significant vaccination programs every winter with the winter flu vaccine. Now, clearly, we don't look to put the winter flu vaccine in as many people's arms as we would want to put a booster for COVID, but that is the undertaking. So I think there's a lot of work underway at the moment to start to plan what that might look like. We clearly don't have the details. So as you've rightly pointed out there, you know, Pfizer are only just starting to look at what their requirements might be in terms of their vaccine at the moment. There's a number of other companies that are providing the vaccine, and we need to understand how each of those responds to the various variants that may develop over time. So I think that there needs to be an element of watch and wait, but we won't be waiting on our laurels. Work is underway to understand and scope what a booster program would look like and how that could be resourced in terms of the clinical staff and nursing staff that need to be released to support delivering that program. But what I would suggest is that the vast majority of that would take place outside of a hospital setting. So in terms of the elective program in a hospital, it shouldn't directly impact on that. However, somebody would need to administer the program, and if that is being delivered via our primary care colleagues, then at the end of the day, somebody does need to be available to make those referrals and see patients initially. So there is a finite resource within the NHS, which is predominantly around the staff that deliver the services, and we can only use those staff once. So we need to look at what are the opportunities for maximising the opportunity for those staff to not only get out there and support delivering the vaccine, but also to continue delivering the day job.
Are you happy with that, David?
Yeah, just to add to that, I know there was moves to get people who had retired back in, but I gather in certain few cases the questions were so complicated that they gave up. Are you thinking of looking at that as another possibility in the cold light of day and saying perhaps we should? Because if you go to a vaccination centre, and I've been, as I'm sure most of us have, it had doctors there, it had medical staff there, and surely some of it could be done by people retired, etc., to allow them, the poor overworked, and I do say that advisedly, overworked healthcare staff to get back to sort of normal. It would just concern me. I know what you say. Pfizer the first, obviously AstraZeneca and the others may come back. Not everybody will take it up, but I think we can be assured that we're getting over this peak now. But it's been said by various people that, you know, we may see a smaller peak maybe Christmas again. Hopefully it's only going to be a small peak, but it's obviously going to be there, and it may be with us for some time. And I'm just concerned that we need to look at having things in place. Thanks, Chair.
Yeah, I mean, I think the retire and the return option is a significant opportunity for the NHS in terms of bringing people back to support with delivering the vaccine. The NHS People Plan also sets out a number of opportunities around looking to grow and expand the workforce as well. So I think the retire and return is probably one string to the bow, and there are a number of other things that need to be explored between now and the start of what would be any booster program.
Are you finished now, David?
Yes, thank you.
Okay, thank you. Where's Mark? Mark, I think is it your turn to come in now, Mark?
I think so.
Off you go then.
Thank you. Are you going to get the presentation up, Caroline, or do you want me to share it?
Yeah, sorry, Chair. I don't know whether Craig Blair needs to leave to go to another meeting, so I don't know whether anyone's got any other questions for him or if they're happy for him to go.
Well, nobody's put their hand up, Caroline, so I'm assuming they haven't. Do you have to go now, Craig?
If that's okay, Chair.
Well, what would you say if I said no?
If you say no, I will stay, Chair. I will cancel my other arrangements.
Okay, off you go. Thank you very much for your input, and I'm sure we'll see you again sometime.
And many thanks for your time, Chair.
Thank you. Bye-bye. Bye-bye.
Thank you, Chair. I'll just bring Mark's presentation up. I'll just be a moment.
So this is just be a brief run through the current situation. Really, there's a few slides that we can skip over, I think, Caroline. Okay, so if you want to go to the next slide, please. Oh,
sorry.
Like an overtired doctor.
I know. Right. Let's see.
About an overtired councillor.
An overtired an overtired fill-in relevant person here.
Yeah.
He doesn't want to play. Don't know why. Don't know what I'm doing.
What about a fed up one? Fed up councillor.
I don't know why. Just a minute.
It was all over and done with. It's like a nightmare.
Yeah, here we go. There we go.
We're off. We're off.
Yeah.
Okay, so this just shows where we are with reference to the rest of the northeast, and this is quite a sort of volatile picture, but all pretty low figures. You can see Hartlepool's bumping upwards a little bit at the moment, and Middlesbrough is kind of round about the late 20s, early 30s in terms of the figure 30 detailed there at the 16th of April, the 7 days to 16th of April, and the current rate is 27 per 100,000, which was 38 cases in the last 7 days. As you can see, 35th nationally. We have been the worst pictures in the country a few months ago, so significant improvement on that.
Again.
Next slide, please, Caroline. So this just gives you a sense of the daily cases that we're getting. So this is by specimen date. So there's a couple of 10s in there, you can see at the right hand side of the graph, but generally below 10, 7s and 8s, and a couple of 3s and 2s. So we are seeing lower numbers, and I expect it to retain that sort of low number volatility, really, because when it's 7s and 8s and 9s, it's generally inflated by 3 or 4 people in a household or that kind of thing. There's no real pattern in terms of specific settings or specific geographies. The numbers are really dictated by a kind of household amplification effect, which you would expect. Next slide, please, Caroline. Again, you can see the rate coming down here, sort of a bit of a plateau from early April, around about that low 30s, early so late 20s. But actually, bearing in mind the economy opened up on the 12th of April, we keep bracing ourselves for a blip following that. We haven't seen that yet from the 12th of April. Schools going back from half term and the shops being open again. We've moved from thinking, well, the 12th of April seems to have been okay, so maybe the weekend will be where things might happen with more people out and about. It's nice weather, and actually being outside isn't so much of a concern. But if people then move into somebody else's house and that kind of potential contamination inside, it's Tuesday, it's probably a bit early to tell, but we haven't picked up anything that might have happened on Friday or Saturday through the numbers yet, so it still looks pretty good. Next slide, please, Caroline. So this is just the age by age group. You can see the yellow line, the impact of the vaccination program, very low rates. I think there's a couple of outbreaks in care homes of low numbers of people that aren't symptomatic but have been picked up through the testing program, which is making those numbers not be zero in regular cleaving. They're around about 0, I think, and I anticipate that ours will get down to that level. Anyway, but you can see pretty clearly the impact of the vaccination program. The blue line, which is 0 to 19, interestingly, with schools reopening and everything, doesn't seem to be picking up massively. In terms of the schools, we've got 3 at the moment, 3 schools, 5 staff, 116 pupils isolating through 6 positives. So the way that it works with the bubbles, particularly in primary school, it doesn't take that many positive cases to isolate to cause quite a large number of children to isolate. But we are working, as we've said before, with schools to keep those numbers as low as we possibly can. And those numbers are lower than I thought they'd be at the end of the first week of schools being back following half term. This is just important, the positivity rate, to give us a little bit of comfort that the low numbers aren't because we're not testing enough. So 1.5% of those tested are positive. We've been up at 15-16% when the numbers really pick up. So I don't think that the low numbers are as a result of low testing. Because the most of the testing is still symptomatic testing, so it's just reflective of low rates in the communities. Next slide, please, Caroline. This just shows that, as we've seen before, there is no real clustering, and these are 1 to 4 cases in each of those areas. These are local super output areas, so they're not quite wards, but they kind of almost translate into wards. But you just get a sense that there's no real clustering that we can see, low numbers. And generally a positive picture. Next slide, please, Caroline. South Tees patients, we've actually, I think Craig had 21 on his slide as at yesterday. I've got 15 from the numbers that I've got in patients and 5 in critical care. And Richard Bellamy at the Health Protection Board, he's a consultant at James Cook. Very pleased with the impact that COVID is having. isn't really significantly impacting on their operations as it was before. So they've just got the usual issues with winter pressures, but not really impacted on particularly by COVID. So that's great. Next slide, please, which I think is probably the critical care. Yeah, 5. You can see very flat critical care picture, gone from 11 at the start of that graph down to 5, and I think that's just symptomatic of some people do obviously get very ill and spend quite a long time in critical care, so that'll take a little while for that to work its way through. And I think South Tees, Richard said, I think it was last week, that James Cook is one of the only areas in the northeast that have got people being treated in critical care but outside of the critical care unit. Which is representative of what else is going on, but obviously 5 patients still there with COVID is making that issue a little bit worse. And critical care beds is always the pinch point in the NHS. Next slide, please. Yeah, so this I don't intend to go through this in any great detail, but this is just we're starting to try to understand the regular testing in schools. To get a sense of who's testing, who's not testing, and this is just the sort of first cut of that. I don't really know yet why the numbers are so low for some of the schools as you go down that table, particularly given that all schools should have been testing. All children were testing 3 times before they returned to school in March. So why there's such variability in the numbers? So we have to dig into that a little bit more. But it's just, I suppose, to assure the committee that we are looking at the coverage of testing in schools from the information that we've got. So we get negative lateral flow results and positive lateral flow results. But again, from the positives, you can see there are a very low proportion of those that have tested. If you look at the bottom line, in total, 119 positives from 76,000 tests, which I think is 0.03% or 0.3%. It's certainly a lower rate than has been prevalent in the community, which is links to the evidence that we had about schools and their impact on the rates. Next slide, please, Caroline. So this is an even busier slide, which is the community testing. I think the bit that we've still got work to do is frequent testing as part of keeping families and communities safe. That's not cut through yet, I don't think. So these numbers in total tests just below 2,000 at Middlesbrough Sports Village, 876 at Newport, and just over 1,000 at North Ormsby, with 7, 4, and 12 positives. So low numbers of positives being found that route, and I think we'll shift to supporting pick-up for home testing more and more as we progress through that. But I think there's still some work to do on what that home testing route looks like. We're looking to target the same groups that we've talked about before, so people in high-risk communities that perhaps have more contact with other people as a result of the sort of jobs that they're doing, be it delivery drivers or working in a supermarket or whatever the sort of roles we've talked about before. Other communities like BAME communities that will be more at risk, and then looking at testing in high-risk settings and testing of key workers who have more contact with people. My gut feel really is that the take-up's probably going to be quite low as the perceived threat of COVID drops, as the economy opens up and as the numbers continue to be low. But if we get this right, it is potentially an important route to identify positive cases early and prevent further transmission. There's a bit of a confusing messages coming from this, where the FA Cup semi-final at the weekend, for example, they did a test to release through lateral flow testing with a single test, and if you're negative, you can watch. It would be better if you did 3 tests in a row like they did before they went back to school, and they used that to emphasize frequent testing as an important part of that approach, because they're not great for finding negatives. They're better at finding positives with high viral loads. But I think there's a little way to go on building clearer understanding of where those tests fit into our overall approach. Next slide, please. So vaccination uptake. So this is of over 16s. Middlesbrough's vaccinated just over 52% of the population. 66,661 people have had a first jab, and I think really that ranking is reflective of numbers of people in that demographic. So Northumberland has got a lot more older people than there are in Middlesbrough, so therefore more of them will have been vaccinated because they'll have reached those cohorts. Same with Redcar and Cleveland to an extent, but also Newcastle and Middlesbrough reflects some of the difficulties in the communities that we have, where I guess health literacy and access to screening programs and vaccination programs are traditionally quite low. So some of the work that Craig talked about in terms of the vaccine equity plan is an important part of ensuring that all of our communities are safe through the vaccination program. So that's the critical part that we're looking to play over the next few weeks and months to get the rates as high as we possibly can in all of our communities. Next slide, please, which I think is another, oh no, it's not. It's a busy one after this one. So this shows, and I think I've mentioned before, the denominator number, the bottom half of the fraction is Office of National Statistics 2019 estimates, which is why you end up with some figures that are over 100%. So we are working with the CCG to try to get better information by age group and by ward if we can from their practice systems, which will be more accurate than those figures. But accepting that the total numbers aren't massively accurate, those percentages are still quite comforting. There's a little bit more work to do on the 80 plus, where there's about, by those figures, there's about 200 people that haven't been vaccinated. So we're working with the PCNs are doing it really, but we're supporting them to look through their systems to try to understand who hasn't been vaccinated, who hasn't been vaccinated but hasn't refused. So that's some of the work we've done. We saw in Craig's slides they've got details of who's actually been refused by age range. So a little bit more work to do that. But in the 75s to 79s and the other sort of lower ranges, very good coverage and very happy with that. Next slide, please, Karen, which I think might be the last one. And I don't intend to go through this, but this just demonstrates some of the work that we're doing to try to understand where we might target our efforts for pop-up clinics or other locally available issues sometimes around, well, they talk about the 3 C's: confidence, complacency, and convenience. So confidence is the sort of vaccine hesitancy type stuff. Complacency is, as you get to the lower age groups, I'm not really that interested because I don't think it's going to affect me. And then convenience is, it's amazing how much accessibility plays a part in driving uptake. So we'll be doing everything we can, particularly in some of those target areas, to drive uptake as much as we can. And those don't relate to ward names because they're the names of the middle super output areas, which is why they're kind of almost wards but not quite wards, which are, and the point of using a middle super output area is they're more kind of regulated sizes in terms of numbers of people in the population rather than wards, which are quite variable. I think that might be it, Caroline, is it? Yeah.
Yeah, that's it.
Okay, happy to take any questions, Chair.
I don't have any questions, but David, would you like to come in?
Yes, thanks, Chair. As we said before, Mark, the figures are coming down low. The thing that did concern me, one was the early one. It said the take up in central Middlesbrough was quite low compared to anything else. In fact, that was it the worst in the northeast and things. I know you looking at addressing that, perhaps having visits around the actual people's houses and things to encourage them to take it up. I know there was some in the mosque, which is excellent. But how do you see Middlesbrough as a whole with the take up of this? Is it just a problem in central Middlesbrough, or is it a problem elsewhere?
I think it probably just reflects the demographics of, Middlesbrough's got a lot of poorer communities, which is where you generally, in the general run of things, it's harder to get people to engage or to have programs that engage them in coming forward, be it child screening or any other sort of program. So it's what we would expect, actually, to be honest. Now, I think it just means we've got to do more work with the PCN. So they've done, it was Holgate PCN actually has done some work with targeting at homeless people and asylum seekers and various other cohorts of people that might otherwise find it difficult to target services. What we've got to do is try to understand those people that aren't in a sort of group like that, but are just in the community. How do we engage them, and how do we encourage them to come forward for a vaccination, or how do we take a vaccination pop-up to where they are and encourage them to be part of that. So part of the capacity building through the community COVID Champions program and working with VCS organisations was around that community capacity building to build confidence when we started, it wasn't about the vaccine, but confidence and understanding of COVID in its entirety. So we've got a lot of capacity to build on to work in those communities. And of course, councillors are critical to that, around messages out and into communities and back from communities about what the issues are around why people can't or don't want to engage. So it's just doing the critical thing for me is that all of our communities are protected. That's the important message, and that's what we'll be working to do. I think we probably don't fully understand all of the barriers, because some of the barriers won't be the sort of thing that you can guess. It'll be working with people to properly understand what they are and doing everything that we can to get the vaccine to them. I think at the overview and scrutiny board, Tony talked about going door to door. We're starting to talk about that, but we haven't actually got any firm plans to do that just yet. But it might be, if it comes to that, and if that's necessary, then that's what we'll do. So everything's on the table to try to ensure that as many people are as protected as possible. That's our aim.
Mark, I do have a question. Sorry. Do you think language is a barrier to it?
Yeah, I think so.
Bearing in mind, Central Middlesbrough will be where the language barrier is most predominant.
I'm sure. I mean, I see the issue with communication is that there's language. If you don't actually understand the language that the whatever written or however the communication is put in front of you, but also general literacy as well, and understanding.
Yeah.
I think quite often the leaflets and the like that are put out are thought to be easy to understand, but they're probably easy to understand from the perspective of somebody that deals with this sort of stuff all the time. And we probably overestimate the sort of general understandability. I know that's not a word, but how we make things easily understandable for people. So I think there's a whole raft of things that we need to understand. And what we try to do all the way through is, how do we build the understanding we're getting through the vaccine program built into how we work from now on? So, for example, one of the things that we're looking to do is connect VCS organisations into the primary care networks, and there's real potential for that relationship to build better and different ways of working as primary care networks develop. So, what we're trying to do with that community capacity building approach is get better routes into communities, so we can get messages through channels that people will understand, be that language or whatever, and also messages back so we have a better understanding of what the issues are.
I think when you put out information, if people who have difficulty with literacy, whether they're English speaking or not, I think once they come across something in it that they don't understand, they possibly just throw it away. They don't try and persevere through the rest of it. I've seen that in children learning to read. If they get stuck on something, they get frustrated and then throw it away. I'm sorry, David, I interrupted there. Do you want to come back in?
Yeah, just another thing about that, Mark. I mean, you said earlier on, and it was pointed out that the rates now, we've just had the open up, and hopefully now things are going to level. It's not going to spike at all. And then, of course, we've got another one next month when pubs will open up for inside. I mean, I saw people last night sat outside in coats and everything, something to have a drink, and I do feel like joining them as well shortly. But the whole point of this is that we need to open the country up, but we've got to do it safely. And if we are going to fully open up by June, which is the plan, and have events back to normal, I don't see it happening as fully as it may seem. But we've got to look at the science. It's your area of expertise to look at that and say, yes, it is happening, or oh dear, there's a spike in part of Middlesbrough or part of whatever. And we may have to sort of look at that again. So how do you see it going? At the moment, it seems very good, but at the moment, we're just doing outside. We're not doing inside yet, and I do feel that's where the problems will occur.
Yeah, I agree. I think once we move to inside, that's where you're going to get more infection crossing over between people. I think I keep working with people in public protection and various other teams just to sort of say, are we doing everything that we possibly can? And I think we've got our business as usual now is pretty robust in terms of the support we give to schools, the support we give to care homes, the contact tracing that we're doing. So we're contacting people as soon as they get their result, we're talking to them about the support package to help them isolate. We're also contacting contacts about the support package as well. So we're doing everything that we can to improve their ability to isolate, working with high risk settings. Judith Hedges' team went out to the pubs on the first, I think it was the first weekend of its first night of opening, and they went out the first weekend as well, and saw some variable practice around wearing masks, around people pulling tables together and all that sort of stuff, which you could guess and you could expect. But we're there, we've got a visible presence, we're, to frame it nicely, we're supporting people to do the right thing, and where they can't or they won't, then we'll take enforcement action. So I think I'm comfortable that we've got everything in place, that if there is a spike, we'll see it quickly and we'll act on it quickly. Now, that doesn't mean that we'll suppress it and we won't see it rise, but I don't think there's anything more that we should have in place. Just to finish on that, the outbreak management plans that we updated a couple of weeks ago have been collated at a regional level, and there isn't anything in anybody else's outbreak management plan that we haven't got in ours. So I'm comforted that we've got. I look for it, hoping really, to be honest, that there will be something that we can do that as well, so that we've got other things that we can do. But I am comforted but not complacent that we've got everything that we should have in place is in place. And in much the same way as we talked about the doctors and nurses and so on in the NHS, really dedicated people doing some really fantastic work within the council and across partners as well.
Okay, David.
Yes, thanks, Chair. It just concerns me that things will be not opening up quite as things as they will, but I think you'll be keeping an eye on that. So, no, thanks, Chair.
Thank you. Nobody else has any questions? No. Right, Mark, we can let you go now. But before you go, can I say on behalf of the committee that we're so grateful for everything that you brought to us, and so grateful for all the wonderful work that you're doing over there under such terrible circumstances. And just thank you very much, and we hope to see you back again soon.
Thank you. I'll pass that on to the team. Thank you. It's certainly not just me. It's a whole lot of people that work a lot harder than I do. Thank you.
Yes. Thank you. Bye-bye.
Bye-bye. Bye-bye.
Okay. Where am I now? Carried away. Right, sorry, I'm miles away there. Sad to see the people go, really, isn't it? You get sort of, you like to talk to them. So I will be back. Right, I think we're up to item number 7 on the agenda, and that's my update on what's been happening, blah, 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 at the OSB. Okay, the OSB met last on April the 8th to consider the following. First of all, the Executive Council's Forward Work Programme. The Chief Exec provided an update on our response to COVID-19, the Executive Council for Communities and Education, Councillor Smyers, gave us her update on what's what in her portfolio. Paul Stevens gave us an update on the progress of Q3 of the strategic plan for the years 2020 to 23. I've lost my other page. Here we are. Last one, Aina Wright and Andrew Humble presented the revenue and capital budget projected outcome position at Q3 for the years 2020 to 21, and finally each scrutiny chair gave their own update. And that's it, apart from any other business. If anybody else has any urgent items, please say so now. If I haven't, I'd just like to say a few words before we close down. This is my final meeting for this municipal year. I want to thank everybody for attending. Some people attended everyone, some people attended not so many for various reasons. I think you were marvellous to work with. There was no hanky-panky, there was no nastiness, no political nastiness or anything. I think we all, particularly the officers, that did an awful lot of work. And I must highlight Caroline, who kept me on the straight and narrow and was very, very helpful for me and very, very patient with me. And whoever the new chair will be, I'm sure we will all, everybody on the committee will back them 100%. And I've never needed to correct anybody. And I've never needed at the beginning of a meeting to say, please remember, we're going live and be careful how you speak and that sort of thing, because you didn't need it, quite frankly. I'm not saying other people did, but this group certainly didn't need it. You all behaved absolutely perfectly. So I'd just like to say goodbye, and I hope we'll meet again. I'm sure we will when we all get back to normal in and out of the town hall. Okay? Goodbye, and thank you very much.
Thank you very much.
Thank you, Chair.
Thank you.
Very nice.
Thank you very much, Chair. Thank you,
Thank you.
everyone.
Thank you.
Thank you.
Good night. Thank
Bye,
you.
everybody.